Hello and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today I'm going to be going over how I assess a wound, okay? So I get this question all the time, like what are the things that I look at when I'm assessing a wound? So I am going to put my wound assessment here and go over each one with you. But first, if you could hit that subscribe button, it would be greatly appreciated as it truly does help my channel. So let's get started. So first I look at the type of wound, okay? So I talk to the patient. How did this wound start? I look at the location of it. What does it look like going on, okay? So I have all of these categories here. So all the different types of wounds that you could possibly have. And I also have in underneath it what you would do, okay? So a pressure injury, you would reduce or remove pressure in that area, okay? Venous leg ulcer, you would do an ABBI and put compressions on them if you can. Surgical opening, moisture infection management, right? So you can see how each one has what you're really doing under it. So you just check off the type of wound first. So pressure injury, venous leg ulcer, arterial leg ulcer, diabetic foot ulcer. Is it a malignant wound? So that's a cancerous wound. Is it a skincare, trauma, burns, surgical open, surgical closed? Okay, so those are all the different types of wounds. Okay, so now we're going to look at the type of wound. Is it healable, maintenance, or non-healing? Okay, so a healable wound. This is a wound that's less than 4 weeks old and it has optimal healing potential. Okay, so there's nothing stopping it from healing. Now, a maintenance wound, it has the ability to heal, but there is outside factors that are causing slow or no progression. Okay, so these could be things like a patient will not wear their compression stockings. Okay, so that would then be a maintenance wound. Now, a non-healing wound, this is over 4 weeks old of a wound, and it's not going to heal due to comorbidities. Okay, so there's outside factors that are causing that wound to not heal. So say it's an arterial leg ulcer. They can't be in compressions and they can't do surgery for whatever reason, vascular surgery. So it's a non-healing wound. It's not going to heal. Then I look at the drainage type. So serous is just your clear, light yellow, watery plasma that's coming out of the wound. Completely normal. Sanguineous is where the drainage is bright red. It's actively bleeding. Okay, so you see that with fresh wounds. Serosanguinous is when it's a pale pink. So you're having your light clear fluid mixed with your blood. Okay, so it becomes this pale pink watery mixture. And then you have your purulent drainage. So this can be thick, yellow, green, brown, tan. It comes in all different colors. That is normally when there's an infection. Next, after I've looked at the fluid color, I want to look at the amount of drainage coming out from that wound. So is it none? Is there no drainage? Is there small, scant amount, a moderate, or large, copious? Now, a lot of people have a problem deciphering where it is here. For the large, copious amounts, you can actually see it running out of the wound, okay? So when there's no bandages on it, you can see it and it almost forms tears, like teardrops out of the wound. We see this in people with venous disease a lot, so venous leg ulcers, where you can literally see it dripping out of the wound. That's going to have a large copious amount of drainage, okay? Now, this is super important step because the amount of drainage is going to decipher what you're going to use as a dressing, okay? As a dressing and a cover dressing. Next, I look at if there is an odor, okay? Does it have a strong, foul, offensive odor? Is it just mild or is there none? Okay, wounds should really have none. Sometimes wounds with like an active bleed and they're bleeding, it will have a little bit of an odor. But if it's that strong, foul, offensive odor, you gotta be documenting this. What do you have? Because a lot of times this will show that, okay, that's a sign of infection, right? Now, talking about signs of infection, we need to determine, is there infection? Okay, so we need to use our NERDS and Stoney's chart. Okay, so if you're not sure what that is, I'll kind of go over it here. So local infection is, they use NERDS, it's called. So non-healing, exudating, red and bleeding, debris, and smell. Okay, now you have to have 3 of these. Okay, so 3 for it to be clinically infected for you to treat. Okay, so if you have 3 of these, so it's non-healing, there's increase in exudate, and there's debris, so the like slough material, then you treat it. Okay, same goes for deep spreading infection, so your stonies, and this you would treat with an antibiotic. Okay, local infection you can treat topically. Deep spreading infection you always treat with antibiotics, and I always personally treat with a topical. Okay, so with that said, you still need 3 of these to have a clinical infection. So increase in size, temperature increase, you can probe to bone, new breakdown, exudate has increased, arrhythmia, edema, so swelling or redness, and a odor. Okay, so you need 3 of those to from either side to clinically treat the wound. Okay, now pain. We need to measure pain, okay, on the pain scale. Now, you can ask them on a scale of 1 to 10, 10 being the worst pain you've ever felt, where is your pain level? You can also show them this chart, okay, this little scale here, and sometimes it's easier for them to visualize it. So they give you a number, but you want them to give you the number. You don't just want to be like, oh, it's moderate, right? Like they're saying they're in a little bit of a pain. Pain is what a patient says it is, and we need to be treating pain appropriately. So you need to be talking to them. Is it only on dressing changes, or is it constant? Because some of the wound dressings that we use, say honey, for example, some people experience it almost like stinging, like a bee stinging them, effect from the honey. So we need to make sure it's not a constant thing. We need to be looking at everything that's going on, okay? If it's just on dressing changes, we could give medication to them to take an hour, half hour to an hour before the procedure. If it's constant, we need to be looking at other things like what is causing this pain. Some wounds are just plain painful. Okay, so they need to be treated for this pain because it does have a series of events in your body and it doesn't allow the wound to heal when you're in pain. Okay, I personally say up to a 3 is acceptable, but ask them what's acceptable to them. Is the pain that they're experiencing acceptable? If it is not, it needs to be treated. And anything over a 4 and up, it needs to be treated. Next, I have a look at the peri wound, okay? Because we need a healthy peri wound for a wound to close in, okay? So is it dry, intact? Is it macerated? Is it excoriated? So macerated is when it's white around the outside. It's soggy, so it's too wet. So we need to be treating this. Excoriated is when it's red. A lot of times we see this if people are having a reaction to the bandage or the tape, so we get excoriated. Is it callous? So it's that thick tissue. It's really just dead tissue that needs to be removed. Is it fragile? Okay. We have to be very careful with fragile tissue, making sure we're not putting adhesives on them. Okay. Is the peri wound weeping? Does it have rash, blister? Is there swelling? So edema? Is there bruising? We need to be looking at all these. Next, we look at the wound base. Okay, is it pink, red? So that would be just a clean, open area, red, pink tissue. Okay, perfect. Is it granulation? So it's more firm, red, moist, pebbly, healthy tissue. Okay, these are acceptable. Do we have slough? So this can be either dry or wet, loose, firm, attached, yellow, brown, dead tissue. Okay. Eschar is dry, black, brown, dead tissue. Okay. Foreign body, so this could be sutures, mesh, hardware. Do we have underlying structures? So bone, tendon, ligaments. Is anything in the base of that wound? Okay. Non-visible. Okay. Is there a portion of the wound bed that you can't see? Deep cavities, sinus tracts. And then anything other that you haven't been able to place in the above categories, you would just note it here, and you're also going to write it down. Okay, what are you seeing? And then you always want to be taking wound measurements. I say on a weekly basis. You can do it every 2 weeks, but you do the length, width, and depth of the wound. Okay, so you take that measurement. And then you also want to incorporate patient concerns. Okay, we always want to look at patient concerns. You ask them, okay, is there something that's going to prevent them from following the care plan? You have to build the care plan around your patient. For instance, I had a gentleman who liked to go bowling on Thursday nights. Okay. Now, how his dressing changes landed, I would be there Thursday morning and I wouldn't be back until Monday. So what was happening is the wound would be looking good, and then Thursday be looking good, and then all of a sudden I'd come back on Monday and the bandage would be off, and something like it would be going backwards. And I'm like, what is going on? And so, through talking to him, I discovered that he was going to bowling Thursday nights, taking off his bandages, taking off the compression that I was wrapping his leg in because it was summer and he didn't want people questioning. So then he just put a really small Band-Aid on it. Okay, so by the time I would come in on Monday, his legs had been swelling all weekend, and it just wasn't good. And we finally figured this out. And so we switched around the days that I was seeing him. So I was coming in on Friday morning. Okay. So he would take it off Thursday night, go bowling, just put a easy bandage on it. So I helped him pick something a little bit that he found was acceptable to wear, and that would be okay overnight. And then on Friday morning, I'd be there first thing, get him back in the compressions. Okay. So it was a lot less time of him being without compressions to cause more damage. So see what I mean? Find out, talk to your patients, and really look at any concerns they may be having, because it might just be the simplest thing as switching from a Thursday morning to a Friday morning. Okay. So I hope this video did give you a better understanding of how to assess a wound and everything you should be looking at. I do have a link. I'll link it up above or down in the description, either or, whatever lets me link. But I will post it where you can actually print this out, okay, a PDF file where you can print out the exact assessment that I use with all of my patients. But that's all I have for this video, guys. I hope you found it very, very helpful, and I hope to see you in my next video. Bye for now.